Welcome everyone, and this is the MIDAS Health Economics subgroup. The MIDAS team in the ARC is the Methodological Innovation, Development, Adaptation and Support theme. So we are a group of methodologists with different expertise. Some of us are health economists, other people are expertise in evidence synthesis, qualitative analysis, and so on. As part of the MIDAS, we form some subgroups which are dedicated to different methodologies. This one is about health economics. And together with Bruce and with Angela Boland, we co-lead the health economics subgroup. And today we are really pleased to host Alex Thompson from the University of Manchester. But I'll leave the introduction of Alex to Bruce, I guess.
Okay, thank you. I'm not going to give a huge, Nobel Prize list of Alex's achievements. Alex, works at the University of Manchester. He can introduce himself in a minute because I know he's very good at this sort of thing. He's a senior research fellow, senior lecturer. Sorry, are you a senior lecturer or senior research fellow, Alex? I should know that.
As of about 4 days ago, I became a senior lecturer.
Congratulations, Alex, to becoming a senior lecturer at the University of Manchester Centre for Health Economics. If you look at his website, he's got loads of research interests, cost effectiveness of digital health interventions, data-driven innovations, diagnostic tests, precision medicines. Fantastic experience, and he's going to be giving us a great talk today on an area I think a lot of people are interested in. Alex has said he's happy to take questions on the way through. If you don't want to shout out and ask a question, type it in the chat, and we'll either ask it on the way through or we'll ask it at the end, and Alex can deal with it then. So Alex, would you be happy to share your screen, please?
Yeah. Can you see?
I can.
Yeah,
perfect.
Yeah. Okay. And I've got quite a nice mic here, but over the past few weeks, something's gone wrong. I think it's something to do with Zoom and Teams, like trying to cancel background sound. So
they don't speak to each other, do they?
If at any point I'm just talking and there's like nothing coming out of my mouth, please tell me without allowing me to go on for 10 minutes. All right.
Okay, will do. Thank you, Alex.
Okay. So this is going to be a first for me. I'm using something called Miro, which I do like to do. I do like to use for brainstorming, but I've never done a presentation for it. So let's see how it goes. So as I said, I'm a senior lecturer in health economics as of about 5 days ago. So this is going to be about digital health, and kind of linked to that is the work that I do, which a lot of it is kind of working with academics, but as well SMEs to help them develop technologies. And there's lots and lots and lots of stuff going on in digital health at the moment. And I'm going to go through some of the reasons why in a second. Okay, next slide. So this is not, if you're turning up hoping for like a intro, methods, results, conclusion, this is not going to be that. This is going to be a bit more of a brain dump. So it's going to meander on different topics, but hopefully that's sufficiently interesting. So the three main pieces of work that I've been on recently to do with this topic, a number of years ago, probably, 2018, 2019, before the pandemic, we did what was called NICE Data Lab. So Innovate UK funded 16 SMEs. This is this bit here. 16 SMEs who had digital health and what was called data-driven technologies. And it was meant to be a collaboration between Health Innovation Manchester, which is our academic health science group at Manchester, the University of Manchester, which I was playing a role, and then NICE, working with the NICE scientific advice team to try and help them get some early ideas, thinking about their methods and how they support companies with their digital health technologies. So it was a really fascinating case study. We worked with 16 companies that had been shortlisted by Innovate. They've basically been given funds to conduct consultancy effectively with NICE, with the university. So me thinking about the health economics. And then there was some work thinking about data safety and interoperability that was also provided by the university. And then NICE was given their scientific advice using some of the tools that they developed. In particular, what they use is called META, which is like a gap analysis. So that's this one here. So that was great. So it was really interesting working with companies, some really cool companies, some terrible companies with terrible ideas, but also some really sophisticated companies with really good ideas, and then lots of companies with really good ideas but not sophisticated. And then onto this. So this is an European Regional Development Fund project, which was a health accelerator. So a similar sort of ticket, really, working with SMEs in the Greater Manchester area. And actually anyone could have formed an SME. So if you're interested and you wanted to get support through this program, you could just create a sort of postal address in Manchester. But in this one, we did the similar thing, but at a much bigger scale. So maybe 50 companies, and I probably worked directly with 25 to 30. So that was medtech, digital health, medtech, medical devices. So again, helping them with the health economics, thinking about developing their ideas. That's that one. And then here, I provide support through what's called Innovation Factory. So Innovation Factory is kind of a part of the university. It's actually at arm's length university. It's a limited company, but it's there to try and help researchers within the University of Manchester commercialise their research. So there's a big push to try and encourage commercialisation. So basically anyone who's got anything to do with life sciences and thinking of trying to commercialise it, often it comes in front of me to look at and to support them and sense check it and brainstorm with them. So over the past, I don't know, 5 to 7 years, I've probably worked with 50 plus different companies. So you get exposed to lots and lots of different ideas. You see lots of overlaps. You see lots of similar challenges. And kind of that's where I'm coming from with this presentation. Okay. So for that data lab piece of work, at the end of it, Innovate UK had a bit of extra money and they wanted me to write a report. So I did a piece of research where I went and spoke to lots of commissioners to get their views on what are the challenges, what sort of evidence do they like, what do they make of innovation, all that sort of stuff. So it was a really interesting piece of work. And some of this here on the screen is basically saying, yes, we have an open door for innovation. So these are people in the NHS. They have an open door for innovation, but the key take home of this particular one page is that they wanted to make sure that innovators had done their homework, because as I'll show you in some following slides, there's lots of movement into this space, and that's to do with the market dynamics and the barriers to entry to some extent. So there's lots and lots of inward interest, people coming in perhaps from outside of life sciences, perhaps from computer science, all sorts of different disciplines with some interesting technologies. So I'm a health economist, if there is such a thing as one, but I think the work that I'm doing is probably slightly different to a lot of health economics work. So I would call that traditional here. So traditional evaluation, often that is, it's kind of what's called a summative evaluation. So it's something that comes at the end of a whole development pipeline. So it's often asking questions like, does this work? Is this cost effective? And it's kind of like once you've come up with the answer, then it's kind of the end of the road. It is or it isn't. And that is quite different to the sorts of work that I've been doing, where you start off much earlier in the pipeline and you have almost a very different mindset. You go into it thinking about an idea, which is very malleable. It's just an idea. There could be good bits of the idea, there could be bad bits, but perhaps your job is to try and shape that idea and make it work. So the context and everything about it is quite different as well. So because you're early on in the pathway, you have to be quite agile And, you know, I'm a health economist, but you almost have to go at it with a very wide set of tools and skills. So doing a bit of evidence synthesis, doing brainstorming, doing a bit of health economics, doing all sorts of things, really. And you have to use different methods because of that. And your mindset is fundamentally different, as I said. So if you're an evaluator, you know, you might be part of an ERG for NICE, you're going into the situation with a natural scientific skepticism to test and evaluate something. Whereas if you're early on in the process, you're working with that particular group to try and help them make a good idea out of it. It's quite a fundamental shift. And to some extent, you become part of the team, but you become slightly arm's length, a friendly critical voice, inputting that evaluative mindset, sense checking ideas, giving an insight on methods and different study types. But also you have some control to direct it and to talk about where this technology might fit in a care pathway. So it's really interesting stuff, and you do get exposed to a lot of ideas. From a pure academic point of view, though, you don't necessarily get a lot of papers because you see lots of stuff that you have to say, well, actually, I think that's not a good idea. And even if it is a good idea, it's not necessarily something that would merit an academic publication. You're just sort of early on and you're helping to shape an idea, but it's actually quite hard to sort of crunch that into some sort of paper. So there's pros and cons of this sort of work. Any questions at any point, just drop in as well. So I don't know whether this is going to work. Let me know. So this is not a digital health technology, but this is an example of the sort of stuff that we do. So Wilbo's Blends, this is a innovation that came through the European Regional Development Fund project. And basically it's to do with kids and adults who have to have what's called enteral nutrition. So rather than, there's a problem with their gastro system basically. So rather than being able to take food as anyone normally would, it has to go direct to the stomach. Okay. So kids from a young age basically have to go on very similar stuff to like formula milk that you would give a baby. And so that's great. And that stopped these children that otherwise would never have got any nutrition and then would have died. Unfortunately, as you can imagine, if you're on that for your life, it's not great for your system because you're not getting all the kind of balanced, well, you're getting nutrition, but it's not perhaps in the right form that is amenable to your body. So tell me if this works. I'll just see if this will play. Can you hear anything?
No.
Not yet.
Can you hear like any funky music in the background?
No.
No. All right. Okay. So, never mind. I'll talk about it. So, what basically I would do with this company, I would have an opening session with them where I would ask lots of really dumb questions. So here, I'm basically asking them, what is enteral nutrition? What's it for? And they're telling me, oh, well, it's for a whole range of rare conditions where children can't eat their food. And then they're talking to me about the challenges that they have. So they would tell me that their kids have got, say, cerebral palsy. Every now and then, in fact, frequently, perhaps 2 or 3 times a year, they might have to go into hospital. And so they've managed to get their kids on blended food. So food that you would cook as a family. And rather than just giving their kids formula, which is not pleasant because they feel like separate from the rest of the family, they would give them blended food. So they would go into hospital, and then because they've gone into hospital, they have to go back into formula, and it would completely mess up their gastro system again. So what I do is talk to the company and try and understand the problem. So first of all, you're getting people to get into the mindset of how does this idea translate into value in the way that the healthcare system might think of value. So if we understand about evaluation, so how would something be evaluated at the end stage, you can kind of work your way back. Okay, well, where's value going to come from this idea? So you basically have lots and lots of sessions where you try and make sense of this idea, come up with different notions of how value could be created. And so you imagine and you come up with narratives. So in this setting, for example, it could be that, okay, well, if we use this product here, which is basically the way I explain it to people, I've got 3 children now, and sometimes a week we can't cook because we're just shattered and exhausted. So we might nip to McDonald's, right? Now this family can't do that, but what they could do is use this product, Wilbo's Blends, which is like it's like a real food that could be put down the syringe for the kid. Okay. So what we want to think is, how could that make sense but to the NHS? Well, when you go into hospital, rather than the hospital giving the kids formula, they could use this blended food. And so what's the cost argument? Well, that stops children having a gastro flare. If they have a gastro flare, they might be in hospital for longer, or you might have a whole range of negative consequences that come from that. Okay, so you can sort of map that out, conceptualize it, and you start developing the idea. And then you pitch the idea and you get feedback. Does this make sense? Etc., etc. So that's one thing that we do right at the start. We basically do a lot of talking and thinking things through, and coming up with the jargon is the value proposition. What's the value from this idea? Okay. So this is kind of a funky diagram to say that. So the starting point is you have to identify an unmet need. So if you're thinking about digital health technologies, and as I mentioned at the start, you've got lots of companies coming in who perhaps are totally clueless to the healthcare system, but they've got a tool they want to use. They've got a hammer, so everything looks like a nail. So you've got to kind of take them on a journey and say, well, where can your tool be used? What's it for? What's the purpose of it? What situation? What's the unmet need that it's actually going to help with? And sometimes they come with an unmet need that they think they've got. It depends on the exact type of person that you're working with. Sometimes they're totally on top of the unmet need. So the Wilbo's Blends example, that was a family that had come up with the idea because they experience that unmet need every day. So they've got a better grasp of it than anyone, but perhaps they don't have a grasp of how you articulate that in the sort of health economic language that makes decisions. So we basically go through this sort of process. Someone might come up with a theory of an unmet need, and a theory of it, we try and verify it. We try and understand what current care looks like. We try and describe like a mechanism through some sort of logic diagram, how this new thing might be good. And then we start to attach maybe costs and benefits to it in a very high level way, just to get a sense of the numbers or the argument. Okay, so let's go to digital health technologies now. So what is a digital health technology? So there's lots of stuff that's appeared over the past 2-3 years now on like the NIHR website, on NICE, all talking about it. There's some really good guides. Here it says it includes smartphone apps, wearable devices such as step trackers. So I've got a Garmin watch which tracks my steps, and it also measures my heart rate. So one could say that might be a digital health technology. And platforms that provide remote healthcare. So what was that one that was in the news? Babylon. I guess that's a digital health technology. But then that's kind of narrow. It's also much wider than that. So software to help track symptoms, online tools to diagnose conditions, programs that analyze data from medical devices. So when you start adding these things, the envelope of what a digital health technology is becomes pretty broad and wide. Lots of things could be considered to be a digital health technology. This is from what's called NICE's Evidence Standards Framework, which I'm going to go through a bit later on. But they mention some similar sorts of things. So smartphone apps, standalone software, tools for diagnosing conditions, programs that can be used for medical devices such as scanners, sensors, or monitors. So these are kind of quite loose ideas, I think, because no one really, well, I'll show you in the next slide. The World Health Organization has taken a different approach to this. This is quite a flexible way of thinking about it. the World Health Organization, I found this the other day when I was researching this for the presentation. They've come up with this thing, which basically is a taxonomy going into the really micro detail. So there seems to be 4 different kind of stakeholders: clients, healthcare providers, health system managers, data services. And you can zoom in, say, healthcare providers. A digital health technology could be something that transmits and tracks diagnostic orders. It could be something that captures diagnostic results. So yeah, this is out there. My impression is this is way too detailed and it's probably not going to catch on. So the essence, what is a DHT? It's quite a broad thing. Anything that's digital, recording numbers on a spreadsheet, could be a digital health technology potentially. Okay, so perhaps rather than thinking of definitions in terms of that, perhaps we simplify and think of some concepts. So how does a DHT, a digital health technology, differ to perhaps other things that we do in healthcare? Well, research and development. So I think most health economists are aware that to develop a medicine takes a heck of a long time, starting with thousands of potential candidate molecules whittled down to one or two that work. And that whole pipeline could cost billions. So that kind of that's reflected in the market dynamic and structure. So you basically have a market that tends to be dominated for new medicines. This is by a small number of very, very large companies. And then you have a sort of secondary market of people competing on off-patent drugs. So you would say very high barriers to entry, and you can kind of see the implication of that is you've got a very sort of monopolistic market. In vitro diagnostics, so these are tests that are done on blood or other biological samples. To develop one of these, I need to change that. It's definitely not hundreds of millions. You're probably looking at 20 million perhaps. And so the market dynamic there, we do have these big players like Roche, Abbott, Thermo Fisher, but also you have a huge chunk of much smaller and medium companies that are coming up with innovations frequently. And, you know, every hospital has got people that could potentially come up with a new molecular test because they've got all the gear. They're looking for particular biomarkers. So the potential for new entrants in this setting is much higher. The bar is lower. It's cheaper to develop these things, and the level of evidence you need is lower as well. You don't need phase 1, 2, 3 trials. It's much lower. Okay, so what about digital health technology? So basically got a kid here, and to some extent a kid could come up with one if they're good at coding and they've got data. So in many respects, the barrier to entry for a digital health technology is extremely low. So what are the barriers? That's something to think about. Privately, what are the barriers privately? Well, I mean, if you look on your phone and if thinking about those definitions of what a digital health technology is, you could probably just go and see hundreds of digital health technologies on Google Play or an Apple Store. You know, you could download them to your own phone. So the barriers to entry, minimal. But what about the NHS? What about the barriers to entry to the NHS? What's the sort of dynamics there? I'm going to go through a bit of that. Another way to think about it is kind of this idea of a public good. So thinking back to microeconomics, is it micro? Yeah. The definition of a public good usually bases on these two kind of separate concepts, whether you can exclude people from using it and whether it's rivalrous. So whether if you consume it, that stops someone else from consuming it. So when I was looking at this the other day, I was thinking maybe it's a club good. So this one here, because you can stop people using them. So it is excludable. And to some extent, it's non-rivalrous because you have costs of delivering the thing, like ongoing costs, like server costs. But I think they're pretty darn low. So I think you've basically got this kind of two-setting model. You've got private goods where you exclude people. So think of a phone app. You just have a license. You can't access the information without paying the license. Is it rivalrous? I think it is. So anyway, I think you've got private goods and you've got public goods, okay, for these types of technologies.
Does it depend on the technology though, Alex?
Yeah, of course.
So
yeah.
like, because some of these digital technologies, say, are for people living in care homes or with dementia or whatever.
Yeah.
And then also, I suppose it depends on whether they have been accepted as something that the NHS will provide, essentially. So like an Apple Watch is private and non-rival.
Yeah.
Is it excludable and non-rivalrous, essentially? But is it still a digital health technology because I use it has a benefit to my health, essentially?
Yeah, I think you're absolutely right, and I think it. Going back to the definition of one, if you've got, say, you've got type 2 diabetes, and you've got like a sensor that's measuring your blood glucose in real time, but you've also got an app that reads it off your arm.
Yeah.
Then that's rivalrous, isn't it? Because me using that stops someone else using it. So
yeah.
You'll have things that sit in all of these different bins, I would have thought, but I think the most of them are going to be, well, your digital apps are going to be in the private goods bin. The public goods are going to have a whole bunch of stuff as well.
Yeah.
But zooming out, it's just worth thinking about how this market differs from your medicines, your diagnostics, because digital health technologies does have the potential to sort of straddle multiple ones of these, which I think is the point I'm trying to make here.
Yeah.
So going back to this idea of barriers to entry, and this is what I commented on before, if you've got low barriers to entry, then pretty much anyone can come in. So you're attracting newcomers to life sciences, but you're also attracting those who understand the needs. So in one sense, a digital health technology potentially could democratize like healthcare. And I've seen companies like this. We've seen like companies that are developing apps for their bipolar, where the person that's come up with the idea is the person that's had bipolar, or people who have been social care workers and they've spotted that the system is just not working properly and they've come up with a solution. So in some respects, it's quite powerful because the people who really understand the problem can come up with a solution. I'm just looking at the time. We're already at past. Wow. So just as a sort of comment on that public thing. So some countries are going into this idea of digital public goods. So the idea is that you don't want to lock your country into using Microsoft to host your healthcare system. You want to have a digital public good. So the infrastructure, you don't want to be locked into a certain company because you have to roll that over every year and you're basically indebted to them. It's really difficult for you to shift once you're sort of in that system. And so this is particularly something that seems to be being led by India. But there's this idea of like digital public goods. So we build infrastructure based on these things that are publicly available, including all the code. So you basically have international developers of open source code, and then countries take it off the shelf and use it for their setting and tweak it. So you're not bound to any one particular company. So again, if we're thinking about this sort of notion of public goods, private goods, the NHS started off with having what was called the NHS app library. And basically you could go on the website. I'm pretty sure very few people ever did this, but you go on the website and they would basically list a bunch of apps that somehow someone had said, yeah, that looks all right. But it's changed. So there's been a 2022, probably 5 health secretaries ago last year, Savage came up with a policy paper which said we're going to lock everything through the NHS app. So the NHS app is going to be our open portal, and everything is going to go through that as the open gateway. But I just typed in Beating the Blues. That's the name of the CBT app that the NHS, that NICE have just recently looked at. So that's not on my Google store, but there was a ton of CBT apps with hundreds of thousands of downloads that are out there that you could say digital health technologies. Okay. And then wider context, there's lots and lots of funding going in, perhaps the nature of the government in terms of it being a conservative government, but there's lots of pumping of R&D funding for people to develop these ideas. And the UK is strategically quite well placed for life sciences, and we're trying to get a march on in terms of AI tools, digital health. So there's sort of national strategies, and you can see that filtering through to the sort of programs that I'm working on. And if you think about the healthcare system, I suppose in one sense, perhaps we do have some sort of comparative advantage that we should exploit by the nature of having a system that's got health records that are linked. And in turn, that makes you think, well, where does the value come from? If you've got some kid that can come up with an app, is the value the kid coming up with the app, or is it actually the underlying data? Is all that value in our data sets, not in the guy that just done a bit of code that ChatGPT might have come up with? Okay, so this made me think back to when I was doing my master's in this idea of choice and competition. So Julian Legrand helped to inform a lot of the decision making for Tony Blair's government, and the idea that you introduce like another market mix into the healthcare system through hospitals. So you choose hospitals, that drives up quality rather than like top down targets or whatever. But for competition to work, it's necessary to drive quality and efficient responsiveness. There has to be competition. There has to be alternative providers from which to choose, and there has to be easy ways for new providers to enter the market. Correspondingly, for failing providers to leave. They can't collude. The competition must be real. So is that something that we want in this space? Do we want people competing to generate products? Perhaps there's real potential here for that, to really drive innovation in a good way and also drive down the price because we've got genuine competition. So what is sort of the antithesis of competition? The barriers to entry. So that's what I was trying to talk about. So it's really quite hard. You see my dog? It's really quite hard for you to just create a new hospital out of thin air to drive competition, but actually it is quite easy to create a new digital health technology because they're really quite simple sometimes if you've got the data.
Could I just jump in a sec?
Yeah.
So one of the things, so I remember all that Legrand stuff. So that's about multiple sellers, right? So that's about supply.
Yeah.
But one of the other features is kind of multiple buyers as well, buyers and sellers in a kind of perfect market or whatever, or in a competitive market.
Yeah.
And is that another feature that is quite? So it's very setting dependent, all this, isn't it? Because in America you've got all the multiple insurers and so on, so you've got lots of different buyers. But actually in the NHS, there's essentially one buyer. Nationally, at least anyway. There may be different things going on locally, and I think that's one of the other themes for this in general, is kind of national versus local. So that was just something that occurred to me. I wonder whether you think that's true about the kind of buyers and sellers. Yeah.
So if we go back here, how do we, if you're like a private consumer, how do you pick your CBT app? Well, it's based on, so the whole argument of health economics is that people don't have good information to make sensible choices.
Yeah.
Perhaps if you can see CBT in the title and everyone's saying, wow, this is whiz bang, it's good value, maybe that's good information. If you've got 500,000 downloads and you've also got 50,000 reviews, then maybe that's good information. To go back to that idea of that one purchaser, if we think about education and all the discussions about like vouchers to go to your school, so you go to any school you want, you just get a voucher to go to the school. Unfortunately, the limited capacity, so you can't choose that. But maybe the NHS could say, well, we'll give you a voucher in a kind of social prescribing way, and you can just go and pick your CBT tool. But that's not the way it's going at the moment. We can get to this, but we have this capacity to evaluate 3 CBT apps that have got this bit of evidence, that bit of evidence.
Yeah.
And those are the ones we're going to recommend. But those have probably been used by about 50 people compared to the whole plethora of ones that are out here. So is there a way that you can abstract from these to sort of say, yep, that's got core CBT, there are CBT elements in that, and then we just let people choose? Don't know. Okay, go through that. So that kind of takes me to here. So the main barrier to entry, as far as I can see, particularly for the NHS, is evidence. Do you have evidence to show that this thing works? And then obviously you can get into, well, what's the right sort of evidence? I guess we can go into that. So here I've kind of got molecules on the left hand side. So these don't change. There's many different types, but fundamentally they don't change. So if you're thinking about producing evidence, randomized trials, phase 1, 2, 3, the molecule is not changing. So to some extent, you can cumulatively build that evidence base over time, and that's good. Thinking about a digital health technology, like, it's a different paradigm altogether. The whole essence of these things is that they're constantly being iterated, improved, made more accessible, getting user feedback, and this happens over very short periods of time, not years. It happens within 6 months that something looks fundamentally different. So we stopped here at 2012. Twitter's changed a lot just within the last 9 months, and it might be a different beast altogether. I've not been on it ever, really. It's good for your mental health not to be. So that poses challenges if you're thinking about how you produce evidence. So if you've got this barrier of entry, which is evidence, well, how do you create evidence if the evidence might not be kind of fit for purpose because the nature of the thing that you're evaluating is changing constantly? So it's probably hard to read this, but basically spoke to some commissioners talking about the NICE evidence standards framework, and they liked it because it gave them a sense of the evidence that you need. And some of them thought it was great. Some of them commented that they were skeptical about the need for randomized trials because lots of the technologies that they were seeing, they just didn't see it as being feasible to do an RCT because of the expense. Don't forget, a lot of these are companies that are developing it, and small companies. They don't necessarily have the time or the resource to do an RCT. And also, if you're thinking about the types of technologies, if it's a monitoring device, do you behave in the way that you would normally if you're in some sort of formal trial? Does that not just fundamentally alter your behavior? Okay, so let's just move on to NICE, up to 42 now. So I'll just go through some of this quite quickly. So NICE released what was called the NICE Evidence Standards Framework in 2019. And they basically classed digital health technologies into a series of risk bands. So at the lowest level, you had, these are like lowest level tier 1. These are like your baseline software systems, like IBM might come with, or Microsoft or something. So they're meant to be really low risk for patients. They're not doing anything that changes treatment. Evidence tier 2 is meant to be sort of, again, slightly higher risk. So some sort of tool that might communicate risk to a patient, or some sort of really simple monitoring device. And then you had 2 other levels, 3A and 3B. So anyway, there's probably not a lot of point going into that in too much detail because they've in my opinion, they've changed it quite a lot. So 2022, they've simplified it at the bottom, you've got tier A, you've got these system services. So again, it's like your software that drives the healthcare system. Then you've got this tier B, communicating about healthcare, diaries, things that might promote good health. And then you've got these tier C at the top, inform clinical management, drive it, treat specific condition, diagnosis specific condition. The idea is as you go up these different levels, the evidence base needs to increase. So this is, I'm trying to just give you some exposure to some of the policy making going on here. So running alongside this, there's been this recognition that if you're developing a digital health technology, you basically need input from lots of different agencies at the same time. So the agencies in the UK came together. So the MHRA, who do regulation, the CQC that do kind of care quality for social and the healthcare system, NICE that evaluate things, and what was the other one? MHRA and the HRA, who basically act as kind of the gatekeepers to research. They came together in what was called a multi-agency advice service, and the idea is that you can go to them, you can go to one kind of shop front and get advice from these different agencies, and the advice is all meant to be aligned at the same time. Okay, so this is something that's just launched, I think, in the past 6 months. It went from being called the MAS, so the Multi-Agency Advice Service. It's changed its name and it's now called this, which is not quite as catchy. Regulatory Guidance of Digital Technology in Health and Social Care. The AI Regulation Service. I suppose it's that bit at the end, the AI Regulation Service, which is a bit funkier sounding. But you can go to this website, and I can share the link, and it's got actually a really nice platform that gives you some information about the sorts of things that I've been talking about, how to develop a value proposition. The idea being it's there to try and help people do that process themselves at quite a low cost. So you've got like some computer scientist that thinks they can help with diabetes. They can go on there and understand that they need to talk to a patient to understand what it's like to have diabetes. It's trying to school them basically. So that's the website landing page. It used to be called the MAS, it's now that. And this is the other big policy change that's coming into place, and that Sajid Javid's sort of white paper last year flagged. So it's this idea of the early value assessment. So this is kind of, I think it's trying to provide companies with an early value assessment. It's trying to get these technologies into the healthcare system more quickly and give them an early insight on the value. And I think they're also meant to be giving them a bit of advice at the same time. So this has been going on, I think, for 6 to 9 months. Have I got anything else on that? So if you Google that, you can come up on a nice website, and I think you can see they've done 9 separate ones. They're focused on depression and cardiovascular disease. And for depression, it's CBT. Now, I was going to go into detail on this, but I didn't have time to pull it together. But basically, NICE have conducted early value assessments for 6 different digital CBT providers. And they've looked at the evidence, and they've kind of said, oh, well, there's barely any evidence, as you'd imagine. There's not going to be a lot of it. But they've made some recommendations. So I think out of the 6 or 7, they've recommended 3 that at least had some trial data. So that's quite interesting. And then you dig into the consultation. So whenever NICE does any assessment, they have huge consultations where people are allowed to comment on it. There's a really interesting comment by someone from NHS England basically saying, well, you've got to be quite careful with this because this has market moving properties. So the 3 companies that got recommended, that's great for them. But for the other 4 or 5, they've not been recommended. And so what does that mean for them? Is that the end of the game for them as companies? And if you think back, okay, is it good that the companies that have got the evidence, do they have the best product? Is that the most usable? Is it the thing that the consumers like the most, that they find most useful? Or is it just sort of historical luck, or they've had data, or they've managed just to get a trial done. So it's kind of thinking about the dynamics of this market here. And is it all about the evidence, or are there certain types of technology like digital CBT, which to some extent is a kind of off-the-shelf thing that's had CBT has had thousands of trials done on it, should be able to abstract that in a certain way to digitize it. Is this not something that to some extent you could almost produce a perfect market for, as long as these technologies conform to certain very basic standards? I'm not sure. So, okay, example. So this is one that I've worked with. So this has come out of the University of Manchester, falls prevention. So this is another one of those kind of no-brainer ideas. So falls is costs the healthcare system so much money. As you get older, your bones become brittle, your muscles wear down. If you exercise, you're much less likely to fall over, and if you do fall over, you're much less likely to break a bone. So if we can just get older people exercising more, that would be hugely beneficial. So there's loads of randomized trials that have shown the benefits of exercise for falls prevention. Could that be digitized? Pretty sure it can. So the team at Manchester, kind of healthy aging specialists, have come up with this platform called Koku, which is basically just an age-appropriate digital app that provides a series of exercises and also the wraparound information about healthy eating and looking after yourself and all that sort of stuff. So the developer trying to get that randomized trial data, trying to get that funding to get that key study that would show the value of the idea. But I think we've managed to potentially get this technology implemented perhaps in Greater Manchester, I think. So I did a bit of work, just basically took off the shelf. Public Health England have got a return on investment tool. It's a really simple model because it's such a no-brainer idea. Currently, it's like Tai Chi. What's the value of Tai Chi? Well, you've got to go and sit in a community room for 8 weeks. So it's got a certain cost to it. A digital app versus that is obviously much, much cheaper. So if you could make the assumption that the effects are similar, maybe not quite as good, but the costs are a fraction, then if Tai Chi is cost effective, then the digital health should be as well. You can do some sort of basic modeling for that. And this is the sort of thing that you help companies with along that pipeline. So you just come up with some simple modeling. It's really easy, transparent, that can be critiqued quite easily because it's so simple. So as an example of how that could have huge impact. So we weren't successful with this, but what's called the ACC, which in New Zealand is their accident insurance thing. It's a slightly strange system, but if you have an accident or fall over, you are insured by the ACC. So they were getting loads and loads and loads of older people falling over, causing them their insurance bills to absolutely skyrocket. So they put out a big tender for a falls prevention digital app, and we bid for it, and I supported them to try and put that together. Unfortunately, we weren't successful, and I think that was probably because the one that was successful did have the RCT in their local setting. But when we looked at that as a technology, in our opinion, it just wasn't anywhere close to the one that we had. It had the RCT, but all the other features that wrap around that were nowhere near as good. But that's the way it went. So yeah, that's the end of my presentation. I hope you didn't mind the kind of slightly meandering style. I'll stop sharing.
Oh, thank you very much, Alex. Bruce had to leave because he had another meeting, so I'm taking over the last bit of this talk. Thank you very much for this presentation. It's really like looking into a very current topic and something that will be increasingly important in the future. I wonder if people have any questions, or you can write in the chat or mute yourself.
You're on mute, Katerina, or we can't hear you.
Can you hear me now?
Yes.
Yeah.
Oh,
You
no,
got
you've
me.
gone again. Read the text.
Text. Okay, so yeah, you had a comment before. Okay, so I'm just gonna read the text. Payback. I have the feeling that this product solutions always needs to be in the southeast quadrant of the cost effectiveness plane, i.e. more effect for lower cost, whereas pharmaceuticals are okay to be in the northeast quadrant, more effect, higher cost. Is that correct? I wonder if the reason is that DHTs are mostly about improving the production technology.
Oh, I can see it. Southeast quadrant, yeah. Well, in my opinion, with drugs, because of that 10-year R&D pathway, and because of the mindset of the developers that they tend to be multinational corporations that are just profit maximizing, it's almost by definition that they're in the northeast quadrant. So they're just cost effective. They extract any potential value. Because of the nature of some of these organizations, like the Wilbos, for example, you know, there's a certain profit motive, but also you're part of a community of people who are struggling with a condition. So you have more complicated incentives. So you're not just profit maximizing. You're not just going to eke out every little bit of value. So there is actually potential for dominant technologies, which is cost saving and more effective, in my opinion. That's why it's a bit more fun, to be honest, because you're working with people that attack, you know, like with academic researchers trying to solve problems, and they have really good intentions as well. But it's also quite cool to work with people who have the same intentions, but from the private sector, because they just kind of they want to get it done.
Okay, thank you, Alex. And I think we got a question from Laura Boland. You want to mute yourself.
Thanks, Lario, and thanks, Alex. That's really, really interesting and useful. I'm Laura. I work at the Innovation Agency, so the HSM for the Northwest Coast. So just a question around, is there a particular approach to economic analysis that you think, as a rule, is better for digital health technologies? You know, would it be, I suppose, fair to say that maybe the more robust end, you know, cost utility analysis, it is not always the best fit? Something like a budget model or you know, a disaggregated like cost consequence model, because it's a bit more focused or a bit more flexible. Is that a better place to start?
Yeah, absolutely. I think cost consequences is what I would suggest. Not fixed decision rules, not thresholds that it just ekes over or doesn't. The problem is, even when you start to, like, if you look at the early value assessment report, I don't know if you have, but if you start off with the idea that this has to be cost utility analysis, but you also take into account these other factors, the weighting between those different elements just is never comparable. It's always about, do we have this data? And oh yeah, well, it's where you sort of focus your microscope. Like, do you focus it on accessibility, like the usability that the patients have, all that sort of stuff, or is it this changes your quality of life by 0.001, in my opinion. So yeah, cost consequences.
Yeah, so I guess it's always best to ask the question of whoever's going to be looking at it and making the decision. Yeah,
so that's another reason. So depending on how you think the way these things are commissioned, a simple analysis that puts things into real units that people can understand as well. This will save you X number of GP appointments. This number of patients said that they're more satisfied with care, that sort of stuff. That's sort of comprehensible to commissioners, whereas it's £28,000 per quality is not quite as, in my opinion.
Yeah, your opinion counts. That's good. So we can. Academic opinion is good. It's in alignment with, I suppose, that's the direction of travel for us. So yeah, it's good to hear. Thanks.
Thank you. And yeah, I think this answer probably covers what Sean was asking about acceptability being captured when the focus is on. I guess within a CCA framework, people should be able to give weight to acceptability, I guess. Any other questions?
I have a really brief one. I'll keep it short because I can see the time. Something that occurred to me, Alex, is that there's the kind of, as you will know from when we've worked together, there's two kind of, there has been two areas of health economics that sometimes do different things. There's a kind of stuff that's focused on medicines and interventions and evaluation. And then there's stuff that is more focused on organisation, services, financing. And I've more focused on the latter. And I just wondered on the extent to which the stuff around digital health, the kind of evaluation approaches that are used in kind of terms of service evaluation, organisation evaluation, so on, whether they're actually more applicable than the kind of evaluation framework we use in the kind of medicines.
Do you be more direct what you're saying?
So what I'm saying is that, you know, for example, if we do something for a local decision maker around, they've made a service, they changed the way services are delivered, and they're just doing it locally because of this local model of the way they want to deliver services. We have evaluation methods using kind of real world data or whatever to try and find a way of providing some evidence around the impact on costs or whatever it is. Are these the sort of methods? Do you not think these methods seem a bit more practical for the purposes of digital interventions than the RCT intervention?
Absolutely. Yeah, absolutely. Well, there's a whole need for real world evidence, which requires that causal approach that policy evaluation has.
Yeah.
But the two things are, there's kind of the two things just need to work much more in hand. Because what I'm trying to show here with this, I suppose, in an implicit way, is the market dynamics and the evaluation do influence each other. So the way it looks to me at the moment with the early value assessment, that's going to lead to a situation where you just have a few small companies that have managed to get that recommendation. Now, whether that actually impacts on commission, I don't know, but you're not going to get that open competition that perhaps might be desirable. But I think policymaking is not sophisticated enough to see the big picture at the moment and see the ramifications of how the particular approach to evaluation then translates back up again to the sorts of things you want. Do you want a really dynamic market in this setting? Can you sort of pick out certain types of technologies like digital CBT? Is that something simple that you can abstract from and say, well, in this area, we can just have loads and loads of people providing that? And I think there's probably other areas as well that are similar.
No, I thought it was really interesting, your point about this sort of wider economics and how that's linked to the sort of the smaller picture that sometimes we get a little bit focused on, which is actually misses the broader context. I can see that we've run over, so I'll put it back to Valeria.
No, I mean, I've quite enjoyed doing this because it's just given me a bit of a break from the day job to zoom out a bit and just put some of these ideas down on paper. And they might not make a lot of sense, but it makes a lot of sense. Thinking out loud a bit.
Oh, that's really good. Thank you very much, Alex, again. And all is left for me to say, thank you, Alex, and thank you for everyone who joined us today. We got another talk on the 8th of June with Professor Joe Cost, so if you're very welcome to join that talk again. We will send another reminder soon. Alex, are you okay with sharing the slides?
Yeah, no problem.
Okay,
if anyone wants to get in touch with me about supporting or anything they're doing on this, or if anyone's got any ideas about this sort of macroeconomic sort of stuff, then let me know as well. All right. Thank you.
Thanks, Alex.
Cheers. Bye-bye.
Bye-bye.